Welcome back to TeqTalk. Today's conversation takes us to the front lines of public health, from SARS to COVID to global challenges we face today. Technology isn't just about apps and dashboard here. It's about saving lives, scaling resilience, and preparing for the next outbreak we all hope never comes. Karen Hay has lived this journey from being an epidemiologist responding to SARS in 2003 to leading pandemic response, and now advising governments worldwide at Salesforce. Karen, welcome to the show, and we are so excited to have you here. Thank you so much for joining TeqTalk. Really appreciate your time, and I'm sure we're going to have an amazing discussion today.
So excited to be here. Thanks so much, Jess.
So let's start with the roots in public health. Karen, you have got great background, great experience in this industry. So when I think of the SARS outbreak, right, in 2003, I think about how unprepared most of the systems were for the speed of the disease, which was spreading that moment of time. And we didn't have the data, we didn't have dashboards or any collaboration tools, which we take granted today, right? And yet for many leaders, that was a moment when technology went from nice to have to mission critical in protecting population, because it was that moment of time when you were just saving lives. Yes. Right? So take us back to those early days. What moments made you realize that technology would be the key to protecting healthcare at scale, people's life?
Sure thing. All the way back to SARS, which I'm really dating myself here, but that was my first big outbreak right out of grad school. My background is in epidemiology of infectious disease. So I was a brand new public health epi, had done just a handful of case investigations and outbreaks, and was really kind of getting my feet under me as a new professional. And SARS hit. And it's important to understand that epidemiologists or epis are fundamentally data geeks, right? We recognize, and so didn't take me long to realize that the data that I was trying to do my epidemiological and surveillance analysis for the population wasn't great. And that to get better data, I needed better systems. So I was new in the job, working with some really brittle legacy tools, like we're talking Foxborough databases that could not be updated. When a new notifiable disease was added for routine surveillance, for example, it took about 6 months or more just to add a new code, right? So these are certainly not agile systems that are needed to support the kind of work that we are doing. So when I joined the health unit, I recognized we've got all these ancient systems that no one really likes and no one really looks at, but we had this legislative requirement to use them. I realized, okay, I need good data to do this job well. So I implemented a lot of data quality processes and data quality checks and things that just kind of hadn't been in place before. So really, really foundational work. But frankly, these tools were just for historical case counting, right? This is, they've got data lags and big gaps in the data that really limited their utility for real-time surveillance or any kind of response work. And certainly the manual processes around how that data was captured did not scale at all, which we learned hard and quickly when SARS hit. And SARS ended up being a bit of a dry run for many things that would come many years later. But it was, the outbreak of my career, I thought, in that it hit the Toronto area very hard. And we had, hundreds of cases. And this was before we even had a reliable test, right? Like the technology has come so that we took advantage, or we took it for granted with COVID that we had a laboratory test available within weeks, but it was months before we had one for SARS. There was a lot more reliance on epidemiological data to identify cases. There's presumptive cases, probable cases, that kind of thing. The sheer volume of the data and the pace at which we had to work completely overwhelmed the department. So as some of the things that I recognized is we had the luxury at the time. I didn't recognize this as a luxury, but it really was. And that after we managed to contain the outbreak, we did not get widespread dissemination of the virus in the community. And the outbreak fizzled out. And we had the luxury of going back and doing post-hoc data cleanup for months and months. So we're talking chart reviews and, faxed over grainy notes from the clinicians and really just trying to make sure that we could kind of fill in the gaps that had existed during the management part of the outbreak. And it gave me a lot of invaluable insights into opportunities for how we could have worked much differently if we had been properly supported by digital tools, right?
Yeah.
Like the FoxPro database was not up for it at all. We used spreadsheets and sticky notes and whiteboards and very, very manual tools.
I can't imagine using sticky notes for millions of people's records. So I know it was tough.
I remember doing a network analysis with a whiteboard and sticky notes. And this was scary because this is when at the point the WHO was shutting down cities, saying you've got disseminated spread, and it was like billions of dollars of tourist impact and economic impact with that decision. So we needed to make sure that we knew how each case it was transmitted. And working on a whiteboard with sticky notes and grainy charts that we were manually reviewing, and we'd finally cracked a case because there was 2 cases where we couldn't say this person got it from this person. We cracked one of them. It was like 1 a.m. We were in a boardroom with all of this stuff. I'm like, this is great. We need to take a picture of this. And this was before we all had cameras on our phones, right? So we were running around trying to, the only digital camera we could find was locked up in the communication director's office, trying to find the keys. I come back into the office and the cleaning staff are in the process of wiping the board. I'm like, what are you doing? We need that information.
Feels to me it was more of an investigation kind of situation, right?
Exactly. So
just not easy at all, and especially during those times when you literally have to save lives.
Yeah.
So great. I think you and your team must have done a great job there. And if you had given some access to today's AI tools or the cloud infrastructure, or do you think something you would have done something differently that moment of time?
Hugely. And I mean, again, it was an honor after that outbreak, I moved around within the provincial public service for the next 20 years. And when the next and in that time dealt with pandemics like H1N1 and large global outbreaks and localized outbreaks. So had a lot more experience at that point around what worked and what didn't. And the key theme here was always timeliness of data and timeliness of communication. Like just those 2 key pieces were so key to any outbreak investigation and response. When COVID hit, we were in fact still using the 18-year-old system for case and contact management system that I built after SARS, which isn't unusual. There's very many other, provincial or state governments that are operating systems that are well older than 18 years old. But again, that had been, our learnings have been kind of funneled into, okay, we now have a tool, and it's a bespoke tool that can support investigative processes and can support the reporting requirements. For routine surveillance, it was 18 years old. It was not going to scale for what COVID was going to throw at us. And we knew that early. So this is where, taking, in some senses, COVID was the do-over for SARS. And from a technology perspective, where we had managed to learn those lessons, the outcomes, and, being supported by digital tools day and night, right? So there's I think we haven't done enough reflection on our pandemic successes with technology because I think we're all kind of burnt out and don't want to talk about COVID anymore. But there was a lot of really good things that happened during COVID because technology had come along so far, and the field of digital health has come along so far.
Yeah. And how long this SARS was there? Was it for a couple of months?
A couple of months. Yeah, I think it was
a couple of months
old. Yeah.
Yeah, but I think it gave the good lessons that we need to now upgrade the technology and the systems and all of that. So moving to my next segment, which is building the provincial health asset. So after SARS, governments knew that they had to do better. This kind of legacy system is not going to work, right? Upgradation is needed in terms of technology, in terms of people mindset as well. So building public healthcare infrastructure is not like building any customer app, right? It's not that easy. So you were designing repositories that millions of people lives would depend upon, immunization records, prescription drug data, outbreak management, and a lot of other different stuff. And what were the toughest challenges you think were that moment of time when you were designing assets of that scale?
I think that my answer here isn't unique to the health space. I think it is a common experience for very many public sector employees. This is sort of the water we swim in public sector. And it comes down to a fundamental misalignment incentives that leads to some pretty dysfunctional governance around the tools and the data. If I had to boil it all down to, what's the biggest wall that I banged my head on, it would be that. So I started on the health, when I moved from the local health authority after SARS up to the provincial ministry of health, I was on the policy side. And I frequently witnessed like technophobia from my policy colleagues, right? They really saw the solutions as the IT department's problem, right? And they don't want to talk about them. They just want that IT guys can go and build a system that's going to fix things without kind of that understanding of you need to understand what the outcomes are that you're going to try to be enabling with these tools. And so this was really exacerbated by, the waterfall delivery methodologies that risk-averse governments love so much, but don't actually deliver very effective solutions. And if they do, they certainly don't deliver them quickly, but they're really good for governance and risk management, I will say. So all of that meant that I would say that the business staff, the health policy staff, were not good at communicating requirements to the IT staff. And the IT staff weren't very good at wrapping their head around the business outcomes that the systems that they're building were aimed to deliver. So that gap, it meant that, really complex processes would get oversimplified just so that it could in the BRD. And then you'd have like a 600-page BRD, business requirements document that took months and months and months to define, and then many, many more months to get the appropriate signatures on. And the signatures were just about, people covering their butts. They weren't necessarily about, do I agree with the contents? And all of this meant that you have, over customized requirements that are very, very difficult to implement effectively. And when they were implemented true to requirement, they're not really probably what you needed, right? So we lacked that iterative, agile way of approaching the problem. There was, endless turf battles over various software and tech stacks across the ministries and the health agencies in the provincial ecosystem. But all of these battles were entirely disconnected from the program outcomes. So it's just this like misaligned incentives and disconnected motives, I think really are the core of the challenges that most public servants working in the digital health space experience. I mean, some of the individual tools are amazing. I call them silos of excellence. There are some great point solution programs for particular problems that work really, really well, but they do not talk to each other. They've reinvented the wheel, everything down to, oh no, we capture our demographic data this way, not this day. Like, so they're not necessarily rooted in standards, but they make all kinds of sense for the bespoke program they're supporting. But they really lack that bigger picture view and that consistency across programs that allows you to start unlocking efficiencies and delivering smarter and at scale.
Yeah. So do you think that people management or, convincing people for any change is much tougher than, adopting any technology?
Yeah, I think in health, because it's been underinvested for decades, right? From not just from a technology perspective, but certainly health technology has been an area of underinvestment. So, I mean, when I joined public health, and I'm old, I'm not that old, the nurses were still sharing computers, right? They didn't even have their own computer on a desk. So you have a workforce that is kind of like, they'll use it because they have to, but they don't sort of see it as their job. They see it as something that they have to use to do their job, as opposed to something that helps them do their job. That is changing generationally. I'll say that, newer grads, we've got new nurses, new inspectors coming in, and they're digitally native, right? But we're in this awkward time, and we'll be for another decade or so, where the approach to technology has so fundamentally changed, and that's really reflected in how the workforce supports it.
Yeah, and I think this is pretty common in different industries as well, that adopting any change, right? Most of the times failure happened not because of any technology didn't work. It's because the mindset of the people, it's because they're not ready to adapt things. So I think it's pretty common. And for healthcare, when you have such kind of legacy systems, people are comfortable with those systems. So you have rightly said that when people do not have the overall picture of the whole vision, it becomes difficult for them to really understand that the technology is also going to really help them overall. So,
and I think another symptom of that exact problem, Jazz, is that we tend, when we do get the business to the table to start articulating requirements for either a new system change or a new system feature or brand new system, it doesn't happen very often. So they feel like they need to get it all on paper now because we're not this is the only chance we have to get it right. So we better get it right now. It just takes a lot of time, and you don't know what you don't know, right? Like you may make a different decision if you had the benefit of a bigger picture that you can gain through a process, like a more agile iterative delivery process. But it's also that there's a bit of a gap in the disconnection between having or wanting to get everything right up front when you're defining your requirements, but also not understanding that to make best use of technology, you're probably going to have to change how you do your business. And there's a lot of reticence there. There's a lot of, this is the way we've always done things, so give me a tool that supports me in this process exactly the way that I've done it for the last 15 years. And they don't recognize sort of the efficiencies that can be gained if you use technology as a true enabler, but that requires that you're going to have to change your processes as well. And again, this is not unique to health, but it's certainly acute.
This is across industry. So people's mindset, when it is broadened with the vision, and when there is no gap, they understand the vision, they adopt things. All right, so let's move on, Karen, to 2020. Let's fast forward to 2020 when COVID hit. Okay, suddenly the public health was under the spotlight in a way that most citizens never had experienced before, right? It was much worse than SARS. It was, I mean, I do not even want to remember those days. I myself was in Canada. So it was a panic time, and dashboards became the lifelines for policymakers. Vaccine tracking became the national security. And yet the pressure on the teams was really immense for the teams, right? Looking back, what do you think, what has worked? And what were the lessons learned during that time in the public healthcare? And you think we should get the systems ready so that in future, for God forbid, we do not want such kind of pandemic to come up again. But in case it happened, then we are ready to, face that situation.
Yeah, it really was. And in many senses, SARS felt like a dry run for what no one knew was coming 20 years later. So we did learn lessons from SARS. We didn't learn them as well as I had hoped, but we had new tools. The tools were then 18 years old, but it wasn't just spreadsheets and sticky notes. We had moved beyond that. But that said, in some senses, because of the state of technology and the state of digital health in 2020, it was an entirely different experience. And as awful as it was, no one wants to go back to those days. I joke, I was not gray before SARS or before COVID. I'm not joking. I really wasn't. It was a very intense.
COVID was a horrible time.
It certainly was traumatic. And regardless of, I am actually really proud of Canada's pandemic response. I think we did exceptionally well. A lot of that is our culture. And what had been a sort of a greater trust in government and willingness to follow public health edicts. Certainly at the beginning, that changed as the outbreak dragged on. But and from a technology perspective, it was, I kind of got to try, I called it pandemic privilege, because I got to try everything I'd ever wanted to do.
How big was your team? And if you can deep dive into what you were doing that moment of time, what innovations would be really exciting to know?
So I was the executive director for public health technology for the province. So I had just actually consolidated all of the various public health apps in that portfolio, including that 18-year-old one I built after SARS. And I recognized we don't have anything in our toolbox that is going to bring what we need. So we ended up taking a leap. And why it was exciting, as awful as it was exciting because it really demonstrated what government's capable if you put your mind to it. And we had this singular focus in a way that I had never experienced in my career, where everyone knew about the outcomes, right? Suddenly, like epidemiological curves, bending the curve, were like a coffee chat conversation, not just like an epi geek conversation, right? So everyone understood what was required. And then from a technology delivery perspective to enable that, things that had been huge roadblocks just fell away, right? Like this governance process usually takes 8 months. We'll do it in 2 weeks. right? Or no, you can't, the legislative drivers for this are going to take 2 years to put in place. We did it in a week and a half. From a technology end, so that 18-year-old system, I've been trying to connect it to our provincial lab registry, because we have a lab registry that has all of these lab results. So where there's a notifiable disease would come in, I've been trying to hook it up to that 18-year-old system for 10 years. Totally depressing, but not unusual. There's lots of 10-year-old projects in the books that could just kind of never make it happen. We did it in 2.5 weeks.
Wow.
And it was just like, look what we can get done when it's everyone's shared priority, instead of little fiefdoms fighting amongst each other, right? Where it's more about the technology than the outcomes. Everyone knew what outcomes we needed to enable. So yeah, pandemic privilege was a thing. It was the silver lining to that awful cloud. And we started with case and contact management, recognizing that we needed to have a really good tracking of cases as they were coming in. If we had any hope of containing the virus, which in early days, we still hoped we could, or at least to limit the spread until vaccines came. So, and again, really typical ministry IT shop, lots of legacy solutions, lots of on-prem solutions, no cloud experience. We didn't know how to procure cloud. We didn't know how to work in the cloud. We didn't know how to manage cloud. We recognized that this is the way we had to go. So we built out everything on a cloud platform. And it was amazing. Started with case and contact management in 5 weeks. Like, that's what agility looks like. Whoa. And then we did, of course we didn't.
And how big was your team?
We had a brilliant SI, so a system implementer. And oh my goodness, I think at a peak, if you consider, because they had offshore resources as well, there's probably like 600 or more that we were bringing to the table. But that was for the full technology program for pandemic for Ontario, which is a big province, about 14 million people. So, we keeps in contact management, did that in about 5 weeks, 2 sprints a week thereafter, just to keep up with the changing science. As the epidemiology evolved, as the science evolved, the guidelines evolved, we would make the changes. And so this looks like, and also because like bench strength, if you worked in public health, congratulations, you're now a contact tracer. This is not your day job, right? We had librarians doing contact tracing. We had dietitians doing contact tracing. So they needed really, really good scripts and guidelines to make sure that they were asking the patients the right questions at the right time. And then those guidelines changed. One day they changed 3 times. No, the incubation or the quarantine period is 10 days. No, it's 12 days. No, it's 14 days. Actually, it's back 10 days. And that was within a day. And usually what you would have done is you would have, faxed out the scripts or maybe emailed out the scripts and, now replace it with this script and just hope that they're checking their email between interviews and using the right version of the script, not the old version of the script. We were able to push that all automatically right in the tool. So they always had the right question at the right time. And it took minutes to make those changes, not weeks to make those changes, right? So we had business analysts doing those configuration changes, didn't need a full development team, did have a full, testing team to make sure that we weren't breaking stuff when we were making these rapid changes. But yeah, so it was heady times in that sense. We also ended up supporting the provincial vaccine rollout, which was the largest vaccine rollout in history. And we built that in 6 days.
Great. 6 days. Never heard of anything getting rolled out in 6 days.
And it did a full tech in the box as well. So we delivered all of the technology, all the hardware required.
And the systems right now are still the same, right? The one which were built during COVID. You're still using the same, enhancing the same. So
Ontario is still using it. I think they have other plans to move on. And that's actually a theme that I'd love to explore, Jazz, is a bit of like my frustration with post-SARS when the lessons we didn't learn is that we weren't ready for COVID, right? And we were maybe a little more ready, but fundamentally there was nothing on our shelf that we could pull off and say, okay, let's go.
I think nobody was ready for COVID. So this was something that it was a shock to everyone. So.
Yeah. And so you've got like the infectious disease folks out there who are saying another one is coming, like it or not. I know no one liked what happened there, but it's going to happen again. And we cannot say when. And I'm really disheartened that we're not ready, that we didn't learn the lessons, and that to me, what those lessons are, let's talk about that. You need flexibility. You need something that can react to changing science and the evolving situation at breakneck speed. You need agility. You need scale. You need the ability to go from, with the pandemic solution, we started off with the first 2 immunization clinics in the country. Every single dose, when it was delivered, was recorded at point of service in this we built. But like I said, we did that in 6 days. only contemplated one vaccine product. Well, then there's a new vaccine product that's available, and there's 2 vaccines, and we had to add another one, right? So that was another one, 2-3 sprints a week to keep up with the changing delivery, changing projects, changing delivery models. We went from big mass clinics, we call them hockey hubs up in Canada because they were often delivered in hockey rinks. And then the delivery strategy changed from these mass clinics, which have a whole different workflow, check-in, triage, all of that, to primary care offices and pharmacies, which are fundamentally more about the one dose at a time. So very different workflow required. So we're able to scale up hugely. At peak, I think we had 70,000 immunizers using the same system. You can't do that with a legacy approach to technology, right? To turn up the dial like that. The system never failed. There was actually, I would say that there was one day where we thought we had designed it beyond all the requirements. And I saw on the news that Toronto Public Health wanted to break a world record and immunize the most people at a single clinic in a single day, which is awesome.
Yeah.
And like, I like that they felt so comfortable in their technology stack that they didn't even call us. So we called them and like, can we send a tech team down just to be careful? Yeah, that'd be great. And sure enough, because this is huge, I think at peak it was like 30,000 doses were provided that day. Like it was an insane number. So many immunizers. We had not planned for world record breaking volumes in our clinic's design, right? So the system started to get a little laggy. And they had paper processes. They're ready to go to paper. I'm like, no, not yet. Give me 10 minutes. Took us 8 minutes to get in, change the configurations so that we could not have all the same immunizers hitting the same database objects at the same time. And that system was back up and running. And everyone who left that clinic left with a dose and arm and a copy of their digital electronic vaccine, proof of vaccine certificate in their inbox and all the data in the central repository. So
great.
That kind of scale.
This is what an achievement is, I would say, that saving lives plus keeping in record, right? It's not easy doing that in such pressure and in such short period of time when you have panic all around yourself. So it's a great achievement, I would say. And yeah, I mean, I feel goosebumps. I get goosebumps when I listen to such stories, and I'm so inspired by the hard work being done by leaders like yourself. And
can we talk about the impact of the data? Because this is me, my epi roots. To me, the systems are cool, but it's all about what is the data doing for the province, for the solution. And this one, again, first time in my career where I could see the systems that I was building having an impact in real time. So because we had the case and contact management system, we knew exactly where every single case in the province was. We knew where they lived, we knew their contacts, we knew their travel history. We had all of that in one system, which we could overlay with every single vaccine dose. So we knew where there was an excess of cases. We knew where there was under immunized populations and on a map and say, oh, wow, there's hotspots of infection. What is it about these hotspots? Well, there are a lot of new Canadians living in big families living in a small apartment. Impossible to isolate in those sorts of situations, right? Or a lot of people who maybe didn't speak English or French or didn't have trust in government. So they weren't going to the clinics, which was still hard to get vaccines. So we partnered with local community because it was a very data-driven response, an evidence-informed response to the problem. Partnered with local community groups and ambassadors, the clinic, the mosques and the temples in the area, went door to door in high-risk apartment towers with people who spoke the languages that the people spoke and said, there's a pop-up vaccine clinic in the parking lot right now. Do you want to come and get protected, right? And so this micro-target those public health interventions because we had the data to do so. And I know I'm a data geek, but that gave me goosebumps, knowing that the effectiveness of the interventions could be monitored in real time. And that's not generally how we get to do things. So it was...
I remember it was me or it was my mother-in-law getting a booster or a shot in the parking lot. And I think one other thing which I want to highlight is that it was not only for the citizens, right? It was also for the tourists. And it was well managed, making sure that distance is maintained and all hygiene is maintained. It was really good, and all the data and all, right? And I mean, overall process, starting from getting vaccine to getting data and then follow-ups and all, everything was so seamless that it really helped in saving a lot of lives.
It really did. And that's how I motivated my team. At our stand-up every day, there was tears shed, and we talked, because we were also living the pandemic, right? So we were all stuck in our homes. We switched to remote work for the first time ever. But we understood what it is we were doing. And I think
there were a lot of changes.
That's how we did the 20-hour days and the, 2-3 releases a week, is because we saw the light at the end of that tunnel, and that we knew that we were building the engine to get us there.
Yeah. Great work, Karen, again. So now let's move on to your next journey. I think your journey has been pretty diverse, right? You have seen a lot of different phases. So now you are with Salesforce and you're bringing these lessons to governments across the globe, right? And the exciting part is now that healthcare leaders are moving forward, and they're experimenting with AI, automation, digital engagements in the way we couldn't really imagine 15 years ago, because of a lot of reasons like budget problems, the gaps between technology and business and all of that. But what we are seeing right now is that AI driven things are all around, be it your cloud powered case management, patient engagement tools. They're just closing all the gaps which we have. So from your perspective, what are certain things which really excite you right now, being a public health leader, and how you're really experimenting with AI and different other digital tools?
I'm really excited about AI. I know, I'm approaching it with I think a pragmatic lens. I think right now AI is a hammer looking for nails. But I also am really, really excited about the impact that it's going to have. We talk about, at Salesforce, we talk about digital labor and how, this is how you're going to reinforce your workforces. And this will really resonate with very many public sector people, because you never have enough bodies to do the jobs, right? HR is always a constraint. And this is where, so I'm actually less worried about, it is a concern in some industries, but I don't think it's a worry in health that people will lose jobs because of AI. I think what it's going to do is help to unlock a whole lot more capability and capacity, and let people do the fun part of their jobs. I don't know any nurse or physician or physiotherapist or nurse practitioner who got into healthcare because they really, really like charting. That's not why they're there, right? So anything we can do to take away the administrative burdens and give them tools so that they can get to the job of providing care, that's a win-win for everyone. On the AI side, there's a couple of, there's the broader, some of the low-hanging fruit is going well. And I'm really happy to see that they've jumped on scribes. So AI medical scribes really, really quickly, just because of that documentation charting challenge. And very, very quickly, it's becoming adopted. And it'll be the gold standard for documentation within 5 years, is my prediction, just because it is working so well. And we're figuring out how to keep the human in the loop in a way that satisfies professional documentation requirements and professional requirements, and also just maximizes the benefit of the tool. So I think that starting with scribes was a straightforward, understandable, and easy enough use case. And it's the foot in the door for AI more broadly. I'm seeing some neat back office stuff. So efficiencies around, logistics and supply chain and, just-in-time delivery for rare products. And there's some cool things that the algorithms are going to help with there. I want to share a use case that I'm really excited about, Jazz. So this is a public health nerd one. I'll tell you a story about COVID again. Yeah. So during COVID, there was a town outside of Toronto. I won't name it, but they had managed to keep transmission of COVID at bay far longer than the rest of the province. So while the rest of the province was all locked down in quarantine, while we were waiting to see what we had vaccines, this city was still open for business, as they said, until it wasn't, because it's because they had a great relationship with their local medical officer of health, a population that really was adhering to the messages that public health was sharing around distancing and masking and everything. All the tools that we had before we had vaccines, they were adhering to them until there was an outbreak that they couldn't crack. There's 25 cases and they could not connect them, meaning community spread. And that's the sort of switch to, okay, no, we gotta lock it down. And so they really didn't want to. They threw everything they had at this outbreak. They interviewed those 25 cases for hours and hours and hours, and were comparing notes and just could not crack it until two nurses chatting over a water cooler said, hey, wait a minute, my case got her nails done too. Where'd your case get her nails done? And it was that little happenstance led to the identification of the nail salon where an infected technician had infected 25 people. But all of that data was there. They just couldn't unlock it because it was in recordings and unstructured free text interview notes. And how do you unlock that data, right? So the chief medical officer phoned me and he said, Karen, do you have any kind of AI tool that could have helped here? And I'm like, that sounds really cool, but it's very speculative. We don't have anything like that. And that's a few years ago, right?
Yeah.
Cool, but no. Well, we do now. And in fact, that's what we've been working on at Salesforce is productionizing. I'm calling her a cyber epidemiologist. And what it's doing is using generative AI and AI algorithms, predictive AI algorithms, to monitor unstructured and structured case data and to suggest potential connections that are being missed. We're training the models on the incubation period and the communicability period of the various pathogens and the epidemiological best practices for the investigation. It's not going to replace an epidemiologist, but what it's going to do is unlock those that are lost. Far too many outbreaks never get solved. Even though the data are there, you're limited in your ability to either codify the data with sufficient granularity to be able to unlock those insights, or even just hold everything in your head. So those eureka moments in epidemiology are really exhilarating, but too far in between. We're going to get a lot more of those with AI.
Wow. That was a very, very interesting use case, Karen. Thanks for bringing that up. And yeah, let's move on to our next section. You're doing amazing things and you have got great experience. So one thing I hear constantly from CIOs and, CTOs in healthcare is that what should I build now so that I do not scramble later and my system remains robust as is and can support even higher use cases? Do you have any suggestions on
there's foundational investments that will
three things, if you can suggest what they build internally now to prepare for the next decade or so?
All right. I'm going to, true to form, as an epidemiologist, I'm going to say invest in your data foundation, invest in your data strategy, invest in your data policies, your data quality. We are in a data economy. And the data that governments and public sector organizations hold is tremendously valuable. And we aren't good at, revenue generation and thinking that way in the public sector context. And it's not necessarily about making money off the data, but it's about unlocking the value in that data. So I would say absolutely spend more time being really, really critical and thoughtful about what your data foundation is so that it's trusted, it's secure, it's comprehensive. That is going to be key to taking advantage of the cool AI tools that are coming as well, because the algorithms are only as good as the data that you train them on. So we really need to be, and this is just an epidemiologist talking, I'm sure, but we really need to be spending so much more.
This is very well said, because this is across all the industries. Or whatever they want to do, implement AI and all of that. If they do not have any great data foundation, the result is not going to be good. So work on data foundation, invest on it, unlock the value of data. So these are such critical points. Anything else you want to add?
Yeah, I think agility and interoperability, you heard me talk a lot about that in the context of the COVID response. Agility is key. Do not try to get it right the first release. Try to get the first release out as quickly as you can and have people kick those tires. So it requires changing how we work in government and public sector. And you need platforms that can support it. Again, it's a very different way of working than custom code, bespoke standalone solutions that can kind of just stand on their little empires and not talk elsewhere. Interoperability is how we must proceed. So you need agility and you need interoperability. And those are two, again, not specific to health or the health industry, but two key considerations for any CTO who's looking at their strategic directions. And then finally, I'm speaking a lot about public health or public sector culture. We really do need a culture change. I was already running an agile shop when I was in the ministry, which made me a total weirdo. But we called it Wagile because we were also still beholden to a lot of the waterfall processes.
Wagile.
Yeah. So I had to kind of feed the beast when it comes to the waterfall requirements and needed, but if the times of, taking 18 months to determine requirements and 3 or 4 or 5 years to roll out a solution, by the time it's rolled out, it's moribund. Like, you need to be looking at ways where it's a fundamentally different way of working. It requires different technology, but more importantly, it requires a different cultural approach to risk and to delivery.
Great. I think this kind of timeline is not going to work now. 3 years or 4 years in implementation, things will change. By the time that requirement may, just die.
Yeah, exactly. Yeah. Oh, and then things aren't important after all.
Yeah. Let me ask you one question. So which country or region you think is setting the gold standard for public health tech adoption today?
There are some really good, I would say, pockets of excellence. Dallas County, for example, they are my go-to example of a public health department that took their pandemic investments and have leveraged them to modernize their entire digital public health infrastructure. Too many. It's a really depressing number of other organizations, because what generally happened is you had new people parachute in for the pandemic response, and then they left after the pandemic was over. And then the poor people who were left behind are burnt out, exhausted, were probably annoyed at the people who parachuted in and shoved the system at them and said, use this. All of that has been lost. And to me, that is a tragedy. If you are not, some of the lessons we should learn is this tool that I built for COVID contact tracing actually works really, really well for chlamydia contact tracing too, right? So just that, use those investments to build. Dallas County has done that beautifully. So I always compliment Dr. Wong there and for his leadership. And because it's something that I really hope we can do more of.
Great.
Yeah, one more point, Jazz, I'd like to raise in the context of advice for CIOs and CTOs is, what is your strategy for introducing agentic labor into your workforce? And sometimes it's a workforce strategy. Like, you should be thinking about your agents like HR, right? In that they need training and performance management and, the sorts of care and feeding professionally that we provide to our human employees. We also need to be considering for our digital employees. And another benefit that we're going to see from the power of bringing the agentic layer into the enterprise is the ability to orchestrate complexities across systems. So this is where, if interoperability is a key part of your foundation, the orchestration that agents can bring, and here the key differentiator between an agent and a chatbot is that an agent can make decisions. An agent can take actions within guardrails to improve processes. So that system orchestration that will be enabled by the agentic enterprise is going to change the game.
Absolutely. Very, very well said, Karen. Really appreciate all your insights, and so glad that you came and talked to us. So let's move on to our last section, where I just wanted to have a quick rapid fire just for fun. If there is any question you do not want to answer, it's fine. You can just say pass. Okay. What's one myth about digital health you would like to bust?
Oh, that's a good one. Digital public health. Yeah. Digital public health is a real thing. So I was at a public health conference not too long ago. I introduced myself as a digital public health practitioner, and I was told that's not a thing. I think that just goes to show that we need to be helping our public health professionals understand that digital is not a separate piece of work, and it's a tool that needs to be in their toolbox. So that's one myth that I would like to bust.
Great. If you had unlimited budget tomorrow, what's the first thing you would like to build?
Oh, huge data platform. I would like a data platform that has a kind of like ingestion engine that can pull from multiple sources, but leave the source of truth there so that you can action the data at the point of system that is all orchestrated with agentic agents, that is secure, and is hosted on Canadian soil, so we don't have any data sovereignty challenges. It's encrypted so that we can make sure that our privacy and security concerns in the health space are well respected. It would have so many cool agents. My digital workforce would be really, really geeky and cool. I love the how they're coming out, and we're kind of anthropomorphizing our agents a little bit, but I think that's a healthy thing, and it's how we approach new technology. So
yes, that's pretty healthy, and
my big investment would look pretty neat,
pretty innovative. So great. Karen, thank you so much. That's all for this session, and thanks for sharing all the insights. We are honored to have you here on the show.
Thanks so much. I really appreciated the opportunity to connect today.